Hello and welcome to the module about the fundamentals of ultrasound for point-of-care ultrasound at Legacy Health. I'm Dr. Gordon Johnson, the Medical Director of POCUS here at Legacy, and really excited to introduce you to the world of point-of-care ultrasound. It'll help your patients tremendously, help you do procedures in a much more safe fashion, get to the diagnoses quicker, and make your professional life more satisfying as well. Note that some of the graphics used in this presentation have been used with permission from Dr. Neelam Soni, who wrote the textbook Point-of-Care Ultrasound that I highly recommend you get to help you in your learning process. So just to go over the goals and objectives of this talk, first we're going to talk about how point-of-care ultrasound differs from referral ultrasound or comprehensive ultrasounds and echoes done in the radiology or cardiology suites. Second, we're going to talk about the physics of ultrasound. We'll talk about the modes and some of the machine settings that you're going to be working with, some of the common terminology used in ultrasound, and also some of the common artifacts that you'll be looking at. So first, discussing how point-of-care ultrasound is different from referral ultrasound. Just like the physical exam, where you have a physical finding, say looking at red, warm, inflamed skin and making the diagnosis of cellulitis and acting on that by prescribing antibiotics, point-of-care ultrasound is very similar. You may see that red, warm skin and wonder if there's an abscess below it. So you would do an ultrasound at the bedside and then act if you do see an abscess, likely just drain it right there. Now, referral ultrasound, which is much more comprehensive, is done after you've made an ask, usually an order in the electronic medical record, and then a tech comes down, performs the ultrasound. The tech has to upload the images, be sent to a specialist such as a cardiologist or radiologist to read. They interpret that, type it out, load it back onto the computer, and then you have to log on to see the result before you act. So point-of-care ultrasound is not a formal ultrasound, and we'll talk about that more in the future, but there are its advantages mainly in time. Also, point-of-care ultrasound is used to assess and reassess the patient. Just like when you make a diagnosis of heart failure, you may diagnose that with POCUS, but also when you start your treatment with Lasix, you'll want to see that the pleural effusions are becoming less, the pulmonary edema is becoming less, the distension of the neck veins and the abdominal veins is becoming less. So you're often rescanning those people, and then at the time of discharge, really confirming that they truly are euvolemic. And then also, obviously, it's used to help guide therapeutic procedures, say thoracentesis or paracentesis of the abdomen is done much safer under point-of-care ultrasound guidance. So again, just to highlight, POCUS is a focused exam with a binary question that it usually answers, such as, is there fluid present or absent in the structure that you're imaging? It's done by the clinician at the bedside and interpreted by that clinician doing the ultrasound. The decision is made in real time and treatments are prescribed. And then again, it helps guide procedures safely if there's some that need to be done. So is point-of-care ultrasound going to make radiology and echo obsolete? Absolutely not. We need them to do more advanced studies, comprehensive studies. They don't answer binary questions. They look at the whole organ, the whole abdomen, all points of the heart, and used advanced functionalities that we don't have. So the next thing people will say is that it's going to replace the stethoscope. There's jokes about the stethoscope now being the wheeze detector, meaning that point-of-care ultrasound can't detect wheezes, but I actually find that both complement each other, and I'll listen to the chest or the heart, and then I'll follow it up with ultrasound, and I think both bits of information are helpful in making a diagnosis. And it's also going to enhance your physical exam as well. So these are all the parts of the body that we can look at with ultrasound. There are too numerous here to discuss, but there's everything from vascular to cardiac to pulmonary, abdominal, renal, soft tissue, musculoskeletal, and goes on and on. So it's good to know a little bit of the history of the ultrasound. Back in the 1880s, the Curie brothers discovered this thing called the piezoelectric effect, and that was when they sent an electric signal through piezoelectric crystals. The crystals would vibrate and emit sound. And the opposite was true as well, as when sound was projected onto the crystals, they would vibrate and give off an electric effect. So this is the hallmark of what was further developed into sonar and later ultrasound technologies. So here you can see the sounds are given off by the probe, and these are given off in frequencies that are higher than is heard by the human ear, hence the name ultrasound. The pulses can be anywhere from 2 to 20 megahertz, and some machines now are even going higher than that. So 99% of the time the probe is actually listening. It sends out a pulse of sound and it's listening for the sounds to come back, and that's how, by interpreting what's coming back to it, it constructs a 2D image. And one of the basic things to understand is the relationship between the frequency and resolution and penetration. It's very simple that with the lower frequency transducers, you're going to get deeper penetration into tissues, but you compromise resolution. So the opposite is true with a high frequency transducer. You don't penetrate very far, but you get very good resolution. And that's important when you're choosing your probes that we'll talk about in the future. Another important thing to understand about ultrasound is it's much more sensitive to see subtle differences in fluid. And here is a bucket of water that was agitated, and immediately after agitation it was ultrasounded at 0, 30, 1 minute, and 3 minutes. 0 and 30 seconds, 1 minute, and 3 minutes. And then it was also CT'd exactly at the same time. And you can see at the CT, there's not much of a change in the fluid. The Hensfield units only go from 17 to 20, which I don't think is probably really detectable by the human eye. But in ultrasound, you can see a marked difference with all the bubbles there that are created with the agitation and then how they dissipate. So how is that clinically important? When you're looking at a pleural effusion like this, you can see tiny little septations or bubbles in air that markedly change your diagnosis. For instance, this would not be a transudative effusion with a look like this. So some of the terminology to be familiar with is called echogenicity, and basically that's just describing how echoic different structures are. So something that doesn't give off any signal would be anechoic, would be completely black, and this is typically liquid, like within a vessel or the bladder. Something can be hypoechoic, where it's giving off less signal than the tissue next to it. Something can be isoechoic, like the tissue surrounding this is all isoechoic within itself. It's nice and homogeneous. And then things that are hyperechoic here, that are brighter and giving off more signal than the tissue around them. So just to show you a clinical example here, in the middle we have a blood vessel in the liver that's likely a hepatic vein that is anechoic. Off to the left you can see the liver tissue itself is isoechoic. The kidney here is slightly hypoechoic relative to the liver. If you look at the parenchyma, it's hypoechoic. That indicates that the liver probably has some fatty liver deposition here. And then finally, the diaphragm behind it, this curved line, is very hyperechoic. So again, just to go on to some of the settings, or what we call knobology, on the machines that you're going to be working with. This is a sonocyte machine here. So the first thing to know is the exam type. And this, you want to tell the machine if you're going to be doing a vascular, cardiac, abdominal, lung, or other study. And then you also can set over on the right the different modes. We're going to talk about those, setting the B mode, or what's commonly called grayscale or 2D imaging, M mode, and Doppler. Then also the gain, which is the brightness of the image, and the depth, which is exactly what it sounds. Here's an example of all the different modes of ultrasound, and we'll go into these individually. First, to start out with B mode or basic mode, grayscale or 2D imaging. This is what you think of when you see most ultrasounds. You see this two-dimensional image. In the middle there is the liver, the lung, and the effusion around the lung. In the upper left-hand corner you can see two vessels, and then to the right you see a cardiac echo. M mode, or the motion mode, is used to measure motion over time. And this here is looking at the motion of the anterior mitral valve leaflet over time and how close it comes to the septum. So you just line this line up just over the tip of the anterior mitral valve leaflet here, and then push the M mode signal again, and it gives you this flapping leaflet there in time, and then you can measure the distance that it comes from the septum. Next, we're going to talk about color Doppler, motion and direction. And here you can see some cars going by me on a street, and you'll notice that the frequency of sound is high and then it becomes low. So this factor is because the sound that's coming out from the cars to me is actually a higher frequency as the car approaches me, and then it becomes a lower frequency, and that changes the tone. And this is important in noting Doppler shifts. So here you can see blood flowing towards the probe in A. It has a Doppler shift. When it's perpendicular, it doesn't pick up much Doppler flow, and that's really important that when you're trying to look for Doppler flow, you want to make sure you're as far away from being perpendicular as you can. And then in C, you're seeing the negative shift there. So here's what we call the angle of insonation. And again, you want to angle the beam so that you're not perpendicular to the vessel, as far away from the perpendicular as you can. You want to have that angle of insonation as small as possible. And again, here's showing the different shifts. There's a positive shift as the blood flows towards the probe here. There's no shift when you're perpendicular to the vessel. And then there's a negative shift when the blood is flowing away from the probe in this view. So here's just how you set the settings for color Doppler. On the sonocyte machines, they're off in the right lower corner of the pad there. And here you can see some tricuspid regurgitation on a cardiac echo. And then over to the left, you'll see the settings on the butterfly machines. You just simply push actions on your home screen there, and you'll see Doppler. And when you push Doppler, it comes on, and there's a little color box you can move around with your finger. And then to change the sensitivity, you can change from high to low flow sensitivity. You can do that on the sonocytes as well to pick up low states of flow, such as this vein here. And then you can move around that color box with your finger. You can also do it on the trackpad of the sonocyte machines. So one thing to be aware of when you're doing color Doppler is remembering BART, blue away and red towards. So blood that's going away from the probe is blue, and blood that's flowing towards the probe is going to be red. So here you can see the splenic vein. The blood is flowing up towards the probe, hence it's red, and away from the probe, hence that it's blue. Now another type of Doppler signal that you'll see, or function rather, that you can use is called power Doppler. And this does not show any direction, but it's very sensitive for flow. And that's helpful in cases like this because this is looking at a lymph node and to distinguish for instance, a vascular organ, which is one that is avascular, and it can see the flow of the lymph and blood within the probe within the node itself. Another more advanced form of Doppler that you probably won't be using initially is pulse wave or continuous wave spectral Doppler, and this is to see flow and actually measure the velocity. So this is used in cardiac to measure velocities over valves typically. Another adjustments that you have to be familiar with are both the gain and the depth. So first to start, we're going to start talking about gain. And on the butterfly machines, you can see you can just change the gain by moving your finger across the screen, either to the left or to the right, to make it brighter or darker. And on the sonocyte machines, the knobs are to the right of the trackpad there. To the left of the trackpad. And here you can see we're just changing the gain of the image. Now remember, if you have a poor image, by just making it bright is not going to make it a better image. Next, we're going to talk about depth, and you really want to optimize the depth here so that whatever you're looking at encompasses basically the top 80% of the screen. You have a little bit of space at the bottom here, and you can see we're adjusting the depth with our finger on the butterflies just up and down. So here now we're looking at that vessel and optimizing it. Here the depth is way too deep, and there it's optimized. So here on the sonocyte machines, again, there's a depth. Here you're getting way too deep, you're wasting a lot of space, and there it's optimized. The other thing to be aware of is what's called the focal zone. There's a focal zone within the ultrasound beam where just with vision, when things are in focus, you can see them clearly. When they're out of the focal zone, they're going to be distorted. And this is important to know. Some of the more advanced machines have this focal setting to make sure you're in the focal zone with whichever structure you're looking at. Next, we're going to talk about some of the common artifacts. You'll see with ultrasound, some of these are actually clinically important and use in diagnoses, so it's very important to understand these. The first one, the most common one probably, and frankly one of the most interesting ones I think, is called the reverberation artifact. And this is created when the sound waves hit something, bounce back, and then hit something in between. So a common example of that is the lung. And here we're ultrasounding the lung. And down here you can see the sound waves. They'll hit the pleural line here and bounce back to the skin, bounce back to the pleural line, bounce back to the probe, and then it sometimes be absorbed. So all that the probe can understand is when something bounces back once, it says that there's something down here. When it bounces back twice, it puts a line down here called an A line. And again, this becomes clinically important. Here's another A line, because A lines indicate that there's air underneath the probe. So this is commonly seen in lung ultrasound. And we'll talk about that further in the lung modules as well. The next one to be aware of is called the mirror image artifact. That I think is very interesting, and that's when a sound wave comes down and hits a curved structure that's typically very hyperechoic. So some of the signal bounces off, will hit a structure over here, bounce back to this curved structure, and then come back to the probe. So that creates this false mirror image down here below. The next effect is called shadowing, and that's simply when there's a hyperechoic structure, the sound waves come down and bounce off of it, and most all the sound waves are returning to your probe, so it creates a shadow behind these hyperechoic structures. So here these are gallstones, typically ribs or other bones will do the same. Sometimes kidney stones, you'll see that as well. So here's another example of a very large gallstone. Now this gallstone of course is round, but you only see the roof of it because of the nature of ultrasound. If the signals are coming off here and bouncing back and leaving this shadow. Edge artifact will do the same thing. When there's a hyperechoic edge like this, it'll leave a little bit of shadow down both sides of it. Now another one to be aware of is called acoustic enhancement, and that's when there's a fluid-filled structure, classically the bladder like this. There's really no impedance of the sound coming down, so the structures deep appear very, very bright. And if you're looking for fluid down behind the bladder, this is important to turn the distant gain down here, because you're going to miss some of those fluid-filled structures if it's too bright, secondary to acoustic enhancement. Another artifact to be aware of is ring down. And this is when the sound signals bounce really rapidly within a structure here. You're getting ring down from a needle that's being put into the tissue here. The lung will also do this when there's interstitial fluid, and it's called a B line. And these are like tiny, tiny little A lines that just go down, down, down. Now gas, of course, is the enemy of ultrasound. If you have gas-filled structures, it just scatters the sound. So that's why you'll see the techs insist on someone being NPO, having a full bladder, because it's transmitted well through the fluid. But sometimes you actually, when you're doing your ultrasound, you're going to have to push down and displace the gas. So we're doing that here in the abdomen. You can't really see much of anything, but when we push down, the gas gradually dissipates, and then you can see the aorta come into view here. Sometimes you have to push down gently for about 10 to 15 seconds to have this effect. So one thing about point-of-care ultrasound is obviously it's not just for radiology and cardiology now. The AMA made a resolution called 802 that said basically nobody owns the sound waves. So each department really determines what the scope of practice of POCUS is within your specialty. So your credentials come through your department. I'm in internal medicine, so my credentials and scope comes through internal medicine. I can't basically decide what OB does, or cardiology can't decide what radiology does. Each one of these are set up by guidelines within our societies. For example, emergency medicine insists on having 25 overread scans of each view you do before you're approved, and also about 25 to 30 hours of ultrasound training before you can use this clinically. And that's the end of the show. Thank you very much. Happy scanning.